Right, I'll make that 10 o'clock. Stuart, do you want to kick off?
Yeah, I'll kick off. Good morning, everybody. My name's Stuart McGivern, and I'm a project manager at the North East Automotive Alliance. Welcome to everybody to join another one of our webinars. This one's going to be on testing, COVID-19 testing. And we've got Laura Gage, our marketing manager, who is going to be behind the scenes, making sure that everybody gets information and the opportunity to ask questions. And I've got John Devitt, who's the CEO of Recovery4Life. Just going to say a few words before we kick off. I think, as you know, testing is a subject that is never off the media at the moment. Every outlet's going on about it. It's very much in vogue. In my experience, to understand a current condition or a problem, you've got to do some investigative work, and I think that's where testing comes into its own. Recovery4Life have put forward this idea of this webinar. I think it's a great idea. Recovery4Life are an NEA member. They're a highly specialist workplace testing, training and treatment service. They do a lot of work in drugs, alcohol and mental health. And John, who's going to be running this session, is the Recovery4Life CEO. He's joined us to provide an explanation of what COVID-19 testing is and what testing will and won't do for your business. A couple of care points as well. There's a chat facility on your screen. If you send information via that chat button, it'll go through to Laura, who will filter the comments, and we'll decide how we're going to tackle questions at the end. And if you have joined, just make sure that your mute button's on so that we can hear everybody talking. So without further ado, I'll hand you over to John Devitt, the CEO of Recovery4Life. Thank you.
Thank you, Stuart, and thank you, Laura. Well, first of all, good morning, everyone, and thank you to the NEAA for inviting us on to carry out this webinar, and also for you for joining us. We want this to be the beginning of a conversation, so please do feel free to put in your questions to Laura. Anything we don't get covered today, we'll have to pull together an FAQ, or our details are at the end. Please get in touch and we can continue the discussion. So from the outset, I'd just like to make the point that the comments I'm going to make are based on our own opinion. It's based on experience, first of all, looking at global research, particularly looking at how other companies and other countries have looked at how they can manage the impact of COVID-19 on the workplace. And also from our experience of working with these tests, we've been really started looking at this in January, a little bit ahead of the curve, when we started realizing that there was something very, very different on the way. So if we could move to slide 1, please. So today, I really want to focus on 3 main things. First of all, what are the reasons that you might want to test? What the sort of tests are that are available to you, and the differences between them. But also, really, the most important bit is what testing can and can't do for you and your business. And the bottom line here is we're living in an absolutely unprecedented times. And testing, as you'll see, as Stuart alluded to, every time you turn the telly on, there's another comment that this test isn't validated, or this test is validated, or is in short supply. And testing is actually quite a controversial issue, but primarily we believe is that there's a lot of misunderstanding about what we're talking about in both public and business debates. And there's also a lack of understanding about how testing can be used, and particularly around issues where discussions around accuracy levels come through. So first of all, if we move on to slide 2, the real reasons for test, and I think we've got to separate these out. First of all, what COVID-19 actually is, first of all, it's a virus which attacks the lungs. Incubation periods going for COVID-19 last up to around 14 days, usually can appear from any time after 3 days from exposure. But also symptoms of COVID-19 really vary in severity and also duration. It's very much, everybody's different and it affects people differently, particularly if they've got underlying conditions. But generally speaking, the vast majority of people will start to feel better, usually after around 7 to 10 days after first experiencing symptoms. Now, there's also been many reports of people who have COVID-19, experience mild symptoms, appear to get better, but then despite this respite, symptoms come back. So it's a serious illness. We really don't understand how it works. There are people who are asymptomatic who can transmit and be carriers of the disease. And what we're seeing in all aspects of testing and around the management of the condition itself is that actually it's a developing field. Nobody really knows what we're dealing with, and every day is a new discovery that people are looking at. So when we're actually looking at the reasons for testing, it's actually about trying to identify and we believe set some benchmarks for individuals to make choices, be that the health service or individual businesses. Now, one thing I would like to say, without making, this isn't any political points or anything like that, but actually PHE in the NHS, there's been a number of statements put out around the validity and particularly the accuracy of testing. And actually, these are all valid comments and statements to make. But we've got to understand that actually, when we're talking from a health perspective, we're a clinical service, the accuracy of the test has a different meaning, because that really primarily is about focusing how testing is identifying illness and how the most ill need to be able to access treatment. And in many ways, we're not talking about access to testing for treatment. We're looking at it in terms of risk management. And the real thing I would suggest, the difference between testing for business and testing for the health service, for example, would be that actually really what we're trying to do is identify wellness rather than illness. If we can move on to the next slide. Now, there's two main types of tests. Some of you may, and I won't go into too much detail today about the difference between them, but fundamentally, there's two main types of tests. The first test is an antigen test. Now, these are carried out by polymerase chain reaction tests. This allows pathogenic organisms such as COVID-19 to be identified using either blood or throat and nasal source material. I'll come back to that in a minute. PCR testing is able to confirm or rule out COVID-19 with a very high degree of certainty. Now, this is the primary test used within the NHS, but also one we've been using with our clients in a back-to-lab setting. And the other main test, which a lot of people are very excited about, and there's a lot of discussion around, particularly around accuracy, are antibody tests. Now, an antibody test analyzes patient's serum, usually from a blood prick, finger prick. The liquid portion of blood that excludes cells and clotting factors but includes antibodies. Now, testing is usually by the ELISA sort of method, which is enzyme-linked immunosorbent assay, which is great for Scrabble, but also is really looking at blood testing is in a way which is well established for both conditions such as HIV and for diabetes. And they're fundamentally the two types that you can drop sort of are currently on offer. And we're going to look at the differences between the two now. If we could move on to the next slide. Right. So antigen tests, what specifically they do is they address and identify the current presence of COVID-19 virus. They're taken through they can be self-taken. We've been using them with businesses where we've given instructions on how to take a swab test yourself from both the back of the throat and from the nose. And once they've received by the lab, the results can be anywhere from, usually 1 to 2 hours, but because of sort of demand, receipt from a lab, you can get a service from 8 hours and but generally speaking 3 to 5 days. They're the antigen tests. If we move on and look at the next slide. An antigen test, what will actually happen is that if somebody is symptomatic and they receive a positive test, what that test will show you is that really recommended is that you have 14 days of isolation from the first time that people experience symptoms. So you can plot, using that test, the two markers of when people started feeling ill and the confirmation of COVID. The research currently is that post the 14-day period, you're less likely to be able to transmit any of that infection to anyone else. And basically, the current advice is that once you start feeling better, you can go about your normal day-to-day business. The problem quite often with these is that actually when somebody is asymptomatic, where they might have the virus and you've got a positive test, but they don't feel ill and haven't felt ill, that's actually slightly different, because what you need to do then is treat from the date of the test for 14 days to look at self-isolation. A negative test, right, and you still feel well, we would just suggest you actually observe 111 advice and NHS guidance, really because you might be that you haven't been exposed to the virus. You may never be, but you haven't been exposed to the virus yet, but you still need to be very careful, particularly of the advice around social distancing. A negative test and symptomatic tests means that actually the virus might not have developed in your system at that stage, or it might actually mean that you have experiencing one of the other many viruses that are flying around at the moment. So the advice for that would be to stay home until you're feeling better. And again, follow NHS guidelines. If we could just move on. Now, the really exciting thing that much media coverage is sort of getting at the moment are the antibody tests. Now, antibody tests really are looking to look at the two types of antibodies the body produces in response to COVID-19, both IgM and IgG. They are instant blood spot tests, very similar to those used for home sort of diabetic or HIV testing. And the real benefit of them, they're quick. You can get them immediately, sort of 10 to 15 minutes. Very simple process. You prick a finger, put a little bit of blood onto a cassette, you add a little buffer fluid, and you get the result almost immediately. Easy to read and very quick to administer. If we could move on to the next slide. However, what an antibody test means is slightly different to the COVID testing. So if we run through the three main types, because straight away you'll see where some of the complications fit into this. If you get a negative test and you have had no symptoms, what this test shows is that it's unlikely that you have had or are carrying the virus. And I say unlikely because research is changing all the time. But that's the current research that has come out of Germany in terms of likelihood. And with all these tests, we're talking about probability. Where you have a positive IgM test and a positive IgG test, it means that you probably had the virus in the past 7 to 28 days. And the advice is that you would continue to self-isolate, as you could transmit the virus even if you're still if you're not showing any symptoms. Because the two bodies means that it's IgM and IgG together mean that actually you have had it, you've produced the antibodies, but the IgM antibody hasn't removed from the system yet, which would mean that the virus is still active. A negative IgM, however, and a positive IgG means that you would probably have had the virus, but your body has created antibody resistance. And that means, and this is the key thing for the workplace, it's likely that you're not able to transmit the virus. If we can move on to the next slide. Now, this is the standard sort of graph that's currently being drawn just to illustrate what I've just talked through. If you look at the crossover where the red line and the green line meet, that is the production point where it's from which you want to start mapping. I'm not going to talk through this in detail, but we'll circulate the slides afterwards and it'll be on the website. But actually this immediately starts giving you a timeline when you start thinking about back to work procedures, particularly if people have been symptomatic. If we could move on to the next slide. So let's actually look, what does this all mean in terms of what testing can and can't do for you? Well, the very first thing I would point out is that the advances of testing are happening all the time. It is a blunt, but it's still a very useful tool. And in terms of accuracy, false positives and false negatives are possible. The tests that we are using for antibodies, for example, are rated as around 98% accuracy and have been widely used in areas such as New Zealand, Australia, most parts of Europe, etc. But they haven't been actually signed off for use by the NHS and for public sector work in the UK. But that's not what we're really talking about, because if we're using these as an indicator of wellness, as we said from the beginning, really it's an indicator we're looking for here against which we can measure actually how people may, within a risk managed way, may be responding to these sort of antibodies and the virus. In terms of long-term immunity, the research just isn't there to guarantee whether people actually, once they've developed antibodies, whether this will give them long-term immunity. Certainly the research shows that the vast majority of people currently will get a short-term immunity, but they really don't know about long-term impact going forward. But the really important thing, as everybody who particularly works in the automotive sector will be fully aware of, all of these issues really do need to be part of your broader risk management approach. Testing in itself will not address whether people are going to be able to work in teams, etc. You have to take a much broader approach. And that's why we've developed with some of our clients we've been developing for a while now, what we call the risk management of people system, which is a means of looking at other factors through which you can sort of assess the impact on your workforce and how to get them back and working effectively as quickly as possible. And two of those indicators might be testing both with the PCR and the ELISA tests at different stages of your journey, basically. If we could move on to the next slide. So we've got lots of questions, which I would suggest if you could just start putting them into Laura now, and here's our contact details. Please feel free to get in touch afterwards. And just moving on to the next slide, in summary, I would just like to cover a few points. The very first thing is, we're in a rapidly changing environment. The understanding of COVID-19 is only just starting. Every day there is a new issue around whether, immunity, whether certain underlying health factors come into play, and whether the development of things like vaccines, for example. But what is interesting, what's guaranteed, is that what the situation is today will not be the same as tomorrow. Now, we can take an approach where, in real terms, this sort of virus and these conditions are going to be with us for at least 12 to 18 months, according to WHO. So, even with the huge developments coming forward, I think we have to, as businesses, look at how we can take control and build a framework for what we, our own businesses, from the information we have at hand at present. And I would, if anybody is interested in sort of discussing these issues or looking how testing or frameworks or risk management might be able to influence your choices going forward, we'd be very pleased to help you and be very pleased to sort of look at that discussion and also look at what other models people have, because this is, if ever there's a time for collaboration and the needs for organisations like the NEAA, I would suggest it's now, where we can all live and learn from each other, basically, to address something which hopefully we'll never see again, but is not something that's going to go away overnight. Thank you for listening, and I would be delighted to take any questions going forward. Thank you.
Hi, it's Laura Gage from the North East Automotive Alliance. If you'd like to post any questions, you can do this through chat, but we do have a fairly manageable amount of people. So if people do want to just ask online by unmuting yourself, then feel free to do so. And obviously it would benefit everybody else as well with the answers. So yeah, feel free to do that if you just unmute yourself to ask any questions.
If I, if I might just chip in, actually, I'd be really interested to see how many people are currently looking at testing as part of their risk management frameworks and for business continuity.
Everybody's shying away.
Has anybody got any questions, Laura? Anybody come through?
One question somebody's asked about the antibodies, and obviously, are you aware whether there's any plans in place for testing everybody in the long run?
Well, there's two things. I think within the NHS, within public service, or sort of wider population, to be honest, I think the priority is at the moment they haven't got a plan to test all frontline essential staff for NHS. So for the NHS, and to put this into context, just the sheer scale of the problem, the NHS employs something like was it 150,000 people? Well, no, it's not. It's 1.5 million people in the UK, something of that sort of scale. South Korea, who did do broad, very far-reaching testing, the most they managed to achieve was 400,000 tests. So in terms of, do we believe that actually there'll be mass screening for sort of UK populations? I think by the time that could or even would happen, I would hope a vaccine would be available, because that certainly isn't going to happen within, I would believe, within the next year.
I guess also there are some people on the line who have probably furloughed a lot of their staff at the moment, so maybe testing might not be something they're looking at currently. So once workforce comes back, and whether that's a managed process in terms of volumes of workforce, and obviously taking into consideration the other guidelines about social distance and etc. What would you recommend for companies in terms of a process of if they have any concerns with any particular staff, should they reach out to you guys for any advice on that?
Yes, absolutely. And I think the key thing here is, if we just wait to see what happens, then in effect you're making it difficult for yourself. We need to start planning now, particularly furloughed staff, because while the crisis is very much focusing currently on people who are ill, quite rightly, the real issue will be what the impact on the workplace will be once people return to work, and actually the preparations for that return to work. Now, whether the furlough might end in 3 weeks or 6 weeks or 9 weeks, there's a whole range of issues that will come through, which including the impact psychologically, around physical safety, about decontamination of sites, deep cleaning. And actually, if you are looking at reintroducing people into a sort of close-knit teams and workplaces, then actually the real risk is, the greatest risk might be from people who are asymptomatic, who've shown no symptoms whatsoever, but actually are returning and potentially could infect the much wider workforce. So we see, because antibody testing is actually quite cheap, it actually is an opportunity to do mass testing on a business by business case. And actually the key thing there is not to try and rush it after people have re-entered the workplace, but prepare to be able to put a program in place for that reintroduction. And that may or may not include factors like taking into consideration situations around where you've got family members who have been ill, for example, but the main employee hasn't been. So a lot of this isn't just about testing, it's about sitting down and working out actually what are the questions you need to ask, and to sort of minimize those risks for that reintegration. And that's really what the risk management of people system is about. It's about looking at, and if this is of interest, we'd be very happy to sort of talk people through that sort of approach, the approach we're advising on managing that wider program of which testing becomes a part.
Where does the responsibility fall in terms of obviously your workforce is back to work, and does it become the employer's responsibility for testing employees that they're concerned about?
Well, I think the issue, you've got to remember, go back to the point I was making about there's two different reasons for testing. The NHS and public services are there for testing to identify people who need treatment. And particularly where you have shortages in, be it testing equipment or ventilators, etc., that's really it for acute diagnosis. In terms of workplace, the vast majority, if somebody's well enough or has had an illness and is coming back to work, they would not fall into any criteria for public sector testing at all. So actually, fundamentally, the really interesting one would be, is there any future claims against somebody who goes to work and catches it on the return to work against an employer? There's a whole range of questions which come into the other sort of risk issues that I've sort of touched on, which we haven't got room to talk about today. But I would suggest that actually all employers, again, just falling in line with HSE guidelines around, wider health, work and workplace health and safety, have a responsibility to try and mitigate risk as much as possible for both the physical and psychological impact that the pandemic has caused. And so for that reason, I would suggest that employers need to show that they've done their very best to support their workforce at this time.
If I can just add something to that, John. I'm doing a lot of work with some of the larger organisations who are doing a lot of preparatory work for getting back to work.
Yeah.
But testing is in the background still, so I think it's something that if you're not thinking about testing, it's going to come on the agenda pretty soon.
Yeah.
So, and the other thing I was going to say was, in terms of the costs, is that something you want to talk about now, or do you want to just do that when you talk to people?
I mean, I'm happy as an indication. See, the key thing with testing is you've got to know what to do with them. So tests in comparisons, for example, the PCT testing, which goes back to the lab, will cost around £200 plus. About £220, because we actually we don't want to profit from this, from the pandemic, basically. So profits are going into what we call the 2020 fund, which is to pay for testing and PPE and things like hand sanitizers for frontline essential staff, such as those working in domiciliary care. But actually, the test in comparison would be roughly £220 for a PCT, and you're looking at the antibody tests coming at only around £20. So it becomes an affordable way of testing, at least getting some indicator of what you're likely to be bringing back into the workplace once furlough ends, and when hopefully we can get back to some semblance of normality.
We've had a question from someone asking how often do you think testing should be done?
Right, it depends on the individuals and what the circumstances and also what the working environment is. So this is where you've got to take these broader risk factors in. We don't actually, and from the outset, we didn't necessarily say you should, certainly at the earlier stages, test everybody, certainly not with the PCT test, because it just becomes, there's only a limit to what that would have shown you. In terms of it's slightly difficult because there's different environments, as I say, and there's different roles. But the sort of factors I would suggest you look at is to look at your workforce and think, well, okay, if everybody's come back together, the more people you test that you can sort of create a baseline with, then you can look at other factors alongside, such as how many people have been ill, how many people's families have been ill, who is most at risk. And I would suggest anybody with a high risk that you're aware of, underlying health conditions, for example, they would be the first people you would test. So you could take it in that you actually do a risk assessment to see who would benefit most from the testing, but then scale it to other people, or just take a full baseline and then monitor it with other ways of going forward as time progresses. And that could mean follow-up testing, depending on, particularly for certain groups.
Okay, Laura, any more questions? Because I think that's 10:31 now.
No, no more questions. Thanks
Okay,
very much, John. Just a quick one for me at the end is just on the screen now is a few of our other upcoming webinars that we've got. 2 further ones this week, one next week, and a one later towards the end of the month. We will still be populating with further webinars as well, based on both member demand and also other changing environments. It may not be yourselves who are the appropriate ones to attend any of these ones, but certainly if you can pass the message around your organisations, and there may be somebody suitable. But other than that, just thanks very much to John from me.
Not at all, thank you.
Very interesting. And certainly if anybody's got any further questions they'd like to explore, I will send a follow-up email with the slides, if we're okay to share, and John's contact details.
Great. Well, thanks very much, John. Thanks everybody for attending, and stay safe. Thanks again.
Lovely. Thanks, Sam.
Cheers. Bye.
Bye.